Dr. Keren Dittmer is a board-certified pathologist by the ACVP with broad experience in skeletal pathology, vitamin D, and genetic diseases. She graduated with a Bachelor of Veterinary Science from Massey University, New Zealand, and completed a PhD at the same institution about inherited rickets in sheep. In Corriedale sheep, when her love and enthusiasm for bones started. She's currently an associate professor in veterinary pathology at Massey University and has published more than 50 peer-reviewed articles and 6 book chapters in these areas. She's also a co-author of Bone and Joints chapter in the 6th edition of Jubb, Kennedy, and Palmer's Pathology of Domestic Animals, and the Tumors of Bone chapter in the 5th edition of Tumors of Domestic Animals. Dr. Karen Dietmer, the floor is yours.
Okay, thanks, Bianca. Welcome, everybody. Thank you for giving up some time on your Saturday or maybe Friday, depending on where you are, to come along to this. I hope that you can come away with at least one, hopefully more, useful bits of information. So I should say that I've had quite a lot of assistance from a couple of board certified radiologists in preparing this, and also in writing sort of the companion article, which is published in Vet Path a month or so ago. And so Sarah Pemberton and Davis-Thompson have been a huge help with this. So the things that I'm going to cover today is first to have a look at the different imaging modalities that we have available, and then the general approach to how you might assess bony changes, mostly on radiographs, and then just a brief look at collecting samples for histology and cytology. And then just to focus on a couple of what I think are diagnostic challenges, and probably the things that I most often get second opinions asked about. So that's looking at reactive versus neoplastic changes. Is it a fracture callus or tumor bone? And then looking at is it an osteosarcoma or potentially some of the other sarcomas of bone. So bone tumours are relatively common in animals, and particularly dogs. They're usually malignant. So depending on the literature that you look at, 90 to 98% of tumours in dogs are malignant, and 92 to 95% or so in cats. And of those malignant tumours, osteosarcoma is by far the most common. So again, depending on the literature that you're looking at, that can be anywhere from 60 to 80 sort of % of tumours. And of course, when we're dealing with our bone tumours, we know that osteosarcoma is by far the most malignant of the different bone tumours. And so getting an accurate diagnosis is really important, because that is of course going to affect the treatment that's given to the animal, and also the prognosis for the animal. So one of the aims of this talk is that hopefully if we're using imaging with cytology and histology, that's going to help us potentially come to a diagnosis in some of those tricky cases, because these three techniques are fairly complementary in helping us with that diagnosis. So as far as our diagnostic imaging modalities that we have available, radiography is by far the most common one, certainly that I see from practitioners and pathologists. It's readily accessible. All practices pretty much would have an X-ray machine, and it's relatively inexpensive. You can also use ultrasonography for assessing bone tumours. And again, this is a relatively accessible technique, but it is highly operator dependent. And so you do need to have somebody who has experience in musculoskeletal ultrasound to be getting some useful and reliable information from that. The other thing is that some of the ultrasound systems that people might have in practice might not be particularly optimized for the superficial nature of some of our bone tumours. And with ultrasound, of course, it can't penetrate the bone, and so you are really limited to having a look at the soft tissues and what the surface of the bone looks like. But it is quite a useful technique in your diagnostic sampling, helping to make sure if you're doing cytology that your needle is going into the right place, or if you're biopsying, similarly that your biopsying tool is going into the location that you're wanting. Our third option as far as diagnostic imaging modalities go is nuclear scintigraphy. And for the most part, I don't think it's particularly common now. When I was in vet school, we used to spend quite a lot of time with horses collecting pee from them after they'd been in scintigraphy. But for the most part, this has been largely superseded by CT and MRI. Part of the problems with nuclear scintigraphy is it's not particularly specific, and so it will highlight areas where you have active bone turnover and also where you might have hyperemia. The other potential problem with scintigraphy is it does also tend to overestimate your tumour margins. Increasingly, we are using CT and MRI in our orthopedic neoplasia cases, and in particular CT is becoming fairly widespread, I guess, in its use. And it is an excellent technique for imaging of skeletal disease. It's great for metastatic screening, and it's also really useful for biopsy and surgical planning. And one of the great things about CT is because of its tomographic nature, you don't have that same issue with the superimposition of soft tissues and other tissues that you do with radiography. MRI in humans, this is the modality of choice for assessing orthopedic neoplasia. It's probably less commonly used in animals, partially because it requires a general anaesthetic and it is extremely expensive. One of the other downsides, I guess, of MRI is that the area of the body that you can image is a little bit smaller than you can with CT. It also takes quite a bit longer to do the imaging, but it is a highly sensitive technique, which in of itself can have some problems, and that is not always that the MRI findings may not necessarily be specific. So if we're looking for, I guess a screening tool, then probably CT is at the moment a little bit better than MRI. So those are our different modalities that we can be using to look at our bony lesions. And further on in the talk, I am going to more specifically talk about radiology and how we're going to use that to assess bone tumours. But I just want to mention cytology, because I think this is a really useful tool for helping us diagnose our bone tumours. As a tool, it has really rapid turnaround time, so that's just the time for you to collect the sample, stain it, and have a look at it under the microscope. In comparison to the larger biopsy needles that we might use for bones, it has a pretty minimal risk of complications. And there's a couple of papers that have looked at cytology versus histology for the accuracy of diagnosing bone tumours. And in one study in particular, they found that cytology and biopsy histology really had pretty similar accuracy in distinguishing between benign and malignant bone disease. So for cytology, the accuracy was around 83%. For biopsy, it was about 82%. And that's when it was compared to the cytology or the biopsy results were compared to histology of limb-sparing or amputation samples. And then the tumour type was correctly identified in about 50% of the cytology samples and about 55% of the biopsies. In this particular study, they only had 17% non-diagnostic cases. And from my discussions with people who look at cytology in diagnostic laboratories, their impression was that they see a lot more non-diagnostic cases of bone lesions on cytology than just the 17% that they found in this study. And they did have a reasonable number of quite poorly cellular slides in that study, about 30%, and then about nearly 50% that were quite heavily blood contaminated. But nonetheless, they still seem to have a pretty good accuracy particularly for distinguishing between benign and malignant bone disease. And in another similar study, they also found that was using ultrasound guided FNAs, and in that study, they found a sensitivity of 87% and a specificity of 100% for diagnosing bone sarcomas. And so, you know, there's a lot of advantages, therefore, to using cytology in diagnosing your bone tumours. You've got that rapid turnaround time, much less risk of complications, and you may be able to make a diagnosis and therefore make collecting a biopsy unnecessary. And one of the great things about collecting cytology samples is that we have an excellent additional test which we can use to identify osteoblasts. And so this is quite long chemical name, but MBT-BCIP is often what it's abbreviated to. And often actually I just call it the ALP stain. It's a bit more convenient than all of the letters. But what this stain does is it highlights cells that have alkaline phosphatase activity. And we know that is a particular feature of osteoblasts. So in cells who have that alkaline phosphatase activity, you see this dark brown to black staining in the cytoplasm of the cell. So we can see here I've got a selection of histology, cytology, and ALP staining of a tumour from a fox terrier. Snoop, he had a lytic lesion in his distal femur. And we can see on cytology here that this is just with diff-quick staining. We've got a population of mesenchymal cells here that are producing matrix, and we've got a reasonable amount of anisocytosis and anisokaryosis, some relatively prominent nucleoli in these cells. So I think, you know, if the whole slide was looking like this, we'd probably feel relatively confident about thinking about sarcoma in this case. And then if you're putting the ALP stain on it, here you can see that we've got this really quite nice brown-black staining in the cells, which suggests that these mesenchymal cells are going to be osteoblasts. And then in the histology over here, you can see that indeed, again, we have this population of mesenchymal cells, which are producing little glassy strands of osteoid. Which is going to be our final diagnosis of an osteosarcoma. So the ALP stain is a super useful technique. I find, for me personally, it works best on unstained slides, but you can also use it over the top of slides that have been stained already with a Romanowski type stain. So these are some examples of just how the stain can look when you're using it over the top of other stains. So this one on the left here, this is when the ALP stain was done on the unstained slide, and then it had a few dips in the blue colour of the diff quick after that in order to stain up the nuclei. And you can see this really nice, intense brown-black staining in the cytoplasm of these cells. This one here, we did the diff quick staining first, and then put the ALP stain over the top. If you're doing the ALP stain after you've already stained it with diff quick or some other type of strain, then you do need to leave it on for longer. So from memory, it's about 10 minutes or so if you're just putting the ALP straight onto the slide, but you're looking at more like 3/4 of an hour to an hour if you're putting it on an already stained slide. And so you can see it's not quite as nice as when you're just using the ALP stain first, but you can still see that we've still got this brown-black staining in the cytoplasm of these cells. Similarly, this one here was a right stain followed by ALP stain. And again, you know, here we've got cells that have really nice features of osteoblasts. They have that nucleus that looks like it's popping out the edge of the cell. They have that quite deeply basophilic cytoplasm, and they kind of look like a shuttlecock, like you might use in badminton. You might call them birdies in America, not a handy on that. But you can still see the browny black material here in the cytoplasm. The one time I have found the ALP stain to not work is if you have your diff quick slide and it's been cover slipped with glue cover slip, and then you need to use xylene to get the cover slip off, then I haven't had success using the ALP stain on slides like that. And when we look at the literature, people have done some studies looking at the sensitivity and specificity of the ALP stain. And on unstained slides, excellent sensitivity, 100%. Specificity slightly less, about 89%, because you will still get the occasional chondrosarcoma or amelanotic melanoma stain positively with this ALP stain. The sensitivity, as you'd probably expect, is a little bit less with previously stained slides. And certainly when I'm using it on previously stained slides, if it's negative, I don't usually rule out the fact that it's an osteosarcoma, because I know that it doesn't work as well on previously stained slides. And the specificity around 94%. So it's a super cheap, easy test to do, and really helps with your, diagnosing that your mesenchymal cell that you've gotten out of your bone is an osteoblast. I guess if you're not going to do cytology, or maybe if your cytology was non-diagnostic, then you might be considering whether a bone biopsy is required. And I do know that pathologists are not uncommonly asked by veterinarians in practice, what is the best way to do a bone biopsy, and what is the best place to collect that biopsy from. So I guess the first thing to consider is, do you actually need a bone biopsy? You might want, you may not need to do a bone biopsy if, the signalment, the clinical signs, and the radiographic appearance are all really consistent with a primary bone tumour. And that's particularly true in countries where fungal osteomyelitis is uncommon. So in New Zealand, we don't have blastococcidioides, histoplasma, any of those type of fungal organisms. And so You know, if we have a dog with a classic signalement and all the radiographic appearance of a primary bone tumor, then you can feel, you know, a little bit more comfortable about the fact that it probably is a primary bone tumor. In countries where you have fungal osteomyelitis, then obviously you are going to have that as your other differential. You may also obviously not need a bone biopsy if you have obtained your diagnosis using cytology. The times when your biopsies are going to be most useful are if your radiographic changes are not classical, or if you're really needing a definitive diagnosis, because that's going to determine what treatment options you're going to use in the future. And I guess particularly maybe what chemotherapy protocols you're going to be looking at. If the vet or the specialist is considering doing a limb sparing surgery, then you may want to suggest avoiding doing biopsy, or particularly just trying to make sure that the biopsy is positioned so that the surgeon can remove the entire biopsy tract at the time of the surgery. There's kind of some quite horrifying literature in humans where they've found that poorly planned biopsies of bone tumors have resulted in unnecessary amputation in about 10% of cases, which seems quite a high percentage to me. And so when positioning for biopsies, these are going to be best positioned by guiding with 2 views of radiographs and as well as your anatomical landmarks, or you can visualize it directly using CT, ultrasound, or fluoroscopy. And then it is quite highly recommended that you do post-biopsy radiographs so that you know, or even intra-biopsy radiographs, so you know exactly where your needle has gone. It can be quite useful information to know, you know, that your needle has just gone obliquely, hasn't really penetrated the cortex, and actually all you've collected is reactive bone, rather than whether you got your needle into the center of the lesion. So one of the best places to sample is the center of the lesion. And then the question is, do you also consider sampling the edge or the transition zone of the tumor? So where the tumor is merging or sort of expanding into the bone. And the literature is a little bit divided on whether this is necessary or useful. So there is one study that looked at the diagnostic accuracy of the different locations for biopsy sampling, and they found that for a central sample only, that had an accuracy of around 84%, whereas if you also sampled from the edge, then your diagnostic accuracy increased to about 92%. If you only sampled from the edge and not from the middle, then your accuracy was fairly poor, down at about 55%. And so, you know, these different locations are going to have different advantages and disadvantages, because if you're sampling from the center of the lesion, then it's quite possible that that area is necrotic, and you may only get necrotic bone or tumor or cells out of that area. Similarly, if you sample further down from the edge or the transition zone of the tumor, then you might actually only get endosteal reactive bone, or potentially you might get a diagnostic sample where you have malignant mesenchymal cells producing tumor osteoid. And then, of course, if your needle doesn't actually penetrate the cortex, there's the possibility that only periosteal reactive bone is sampled. And we're going to talk about the distinction between reactive bone and tumor bone quite a bit more in a second. And this is what your edge or transition zone can look like. So this is in the medullary cavity of a bone. This is our bony trabeculae, which have been thickened with new bone production as part of the reactive process. And then we also have a lot of reactive bone being formed here. But you can also see that we have this wave of tumour cells that are just permeating through that medullary cavity and making their way deeper into the bone. So yeah, I mean, I guess that's why, you know, you may or may not have an improved accuracy if you're also going to sample this area of the tumour. If you only sampled up here, then you're only going to get that endosteal reactive bone, whereas if your needle was just slightly further over, there is the potential that you could get some tumour. So as far as sampling methods for our bone biopsies, we've got a few different options. If we're going for a less invasive type sampling method, then our Jamshidi needle is one that we can use. That gets us pretty much our smallest sample size of our different sampling options. The next sample size up is the Michelle, hopefully I've said that right, bone trephine. And that gets you a larger sample, but because you've got a, you're making a larger hole, then you do have a greater risk of iatrogenic fracture with these trephines over a Jamshidi needle. And then you might also consider an open biopsy. This is the technique that has the greatest fracture risk, but might be useful, particularly if you have periosteal masses, particularly ones that are quite hard that you're really struggling to get a good sample out of, or if you have really large lesions or lesions that are involving whole bones. Again, this might be a good technique. And in some cases, if your tumour has eroded a significant amount of the bone, you might actually just be able to get you know, a sample with a scalpel if the tissue, you know, that underlying tissue is really soft. And then of course, amputation is your ultimate sampling technique whereby you get the whole tumour. Okay, so quite often what one of the fundamental questions that we have when looking at bone biopsies, and I've termed it Diagnostic Challenge number 1, is what you're looking at a reactive process or a neoplastic process? And it seems like such a fundamental question, but oftentimes I think it really is one of the hardest questions. And so this is where using your imaging in combination with what you're seeing on your biopsy can be really helpful in getting to a diagnosis. So when a radiologist is looking at their imaging, and I'm sure we must have been taught this in vet school back in the day. I found it really amazing working with Sarah and Devon and working through a lot of this imaging stuff, because yeah, it has been extremely helpful for me. So the things that the radiologist is assessing is the location of the lesion, the extent of the lesion, and then the lesion morphology. And based on that, they are able to classify the lesion as aggressive or benign. Then once they've done that, that is combined with the signalment of the patient, any other history and other imaging findings to develop a differential diagnosis list. The imaging finding, there's not many diseases that have specific imaging findings, because there's only so many ways that bone can respond to things. But when it's combined with the patient signalement and the location of the lesion, the history, then you are able to use that to prioritize what is on your differential diagnosis list. So when a radiologist is looking at lesion morphology, they are looking at that to assess how biologically aggressive a lesion is. And so basically, if a lesion is more ill-defined or poorly delineated, then that tends to suggest that you're dealing with something that's changing rapidly, and you're dealing with a more aggressive type disease. And when we're talking about aggressive features on bone imaging, we're talking really about malignant neoplasia or potentially a severe osteomyelitis. In comparison, if you have lesions that are well-defined or well delineated, then this tends to suggest that you're dealing with a slower process. And these are the sort of things that are going to be more associated with a benign disease, so something like a bone cyst or a benign tumor. And these two things, whether it's ill-defined or poorly delineated or well-defined or well-delineated, are used to assess how the periosteal reaction looks and what the bone lysis looks like. The other thing that's assessed on lesion morphology is the zone of transition. So if you have a long zone of transition in the bone, then that suggests a more aggressive type lesion. If you have a shorter zone, then that's going to be suggestive of a more benign lesion. And so when you're reading radiology reports, just like we have with pathology, there's a whole lot of terminology that goes with those reports. And so I'm just going to go through some of the common terms that you might come across, because either having the radiographs and or the radiology report is going to be quite helpful for also looking at your biopsy. So when it comes to the morphology of the periosteal reaction, there is a spectrum that goes from a solid periosteal reaction, which is at the benign or the inactive end, through to, on a continuous scale, an amorphous periosteal reaction, which we see with an aggressive or active type lesion. And so a smooth or a solid periosteal reaction on radiographs is quite, I guess, as the name would suggest, it's relatively smooth and it's solid. And so we have these really well-defined margins. It's really just kind of this smooth, slight kind of thickening of the cortical bone that you can see here. As with this one, you can see that it has actually almost pretty much become confluent with the cortex. So this is an elbow from a dog who has a panosteitis lesion. This one here is a mature fracture callus, and again, we have this really smooth, it's got relatively even opacity. And again, it's relatively confluent with the cortex. So this is a nice benign or an active type periosteal reaction. Sort of the next level up, we have what is known as a lamelated or an onion skin type appearance. And this is when we have sort of, as the onion skin name would suggest, concentric or lamellated layers of periosteal bone. Again, it's quite well defined. It's just that you can see, you know, a slight subtle difference in the opacity of the different layers. So as you move outwards from the cortex, then you get this slight change in opacity, which is what gives you the layered appearance. Next level up, and this is kind of in our mid-range between benign and aggressive, is a brush-like or columnar or palisading type appearance. And this can be divided into palisading or thick brush-like, and then spiculated or thin brush-like reaction. So this is where we have multiple short parallel lines that are radiating off the cortex perpendicularly. And so you can see in this one here, we've got these quite thick, almost sort of columnar type periosteal reaction coming off this cortex. Similarly, down here, this is from a chronic septic arthritis. Again, you can kind of see this sort of thick brush-like periosteal reaction. This one is getting a little bit thinner, so edging towards the more aggressive side of the spectrum, where we have a thin brush-like or spiculated appearance. And on the more benign side of the spectrum, the margins are usually relatively well defined. And as you edge towards that aggressive side, then they become more ill-defined. Now we're sort of on the aggressive side of the spectrum, and this is our sunburst reaction, which we quite often, personally, I often associate with osteosarcoma, where we have a really aggressive bone lesion. And this is where we see these multiple thin, they're quite thin radiating lines coming off the cortex here, kind of like the rays of the sun, if you can get your imagination in there. And they can extend, they can be quite long, so you can kind of see that these are actually extending a reasonable length out into the soft tissues here. And again, this one here, you know, really you can imagine those sun rays just bursting out of that bone. And then on the very aggressive end of the scale, we have our amorphous or disorganized periosteal reaction. And this is where we just have irregular, ill-defined areas of opacity. And so you can see, again, both of these examples are osteosarcomas. Here, we just have this sort of patchy areas of radio opacity here in the soft tissues and kind of radiating out here as well. And you may also, you know, at this point, have quite a lot of severe bone lysis as well. You can see here that this fibula, I think, has just about completely disappeared here. Okay, so that's the morphology of our periosteal reaction. And we have a similar morphology or scale when we're looking at our bone lysis. And so we have at the benign end of the spectrum, this geographic area of lysis through to a more expansile, but still relatively contained area of lysis, through to our moth-eaten and permeative lysis, where at this end, we're getting to our aggressive side of the spectrum. So with our geographic bone lysis, this is well defined. It's often circular, and you may have a thin rim of sclerosis about it, around it. And it's usually a single area of lysis. And so you can see here, this is a radiograph from radio-ulnar ischemic necrosis. And we have this quite well-defined area, quite circular area of lysis. Similarly up here, another geographic well-defined area of bone lysis. So this is well on the benign area edge of the spectrum. Leveling up, we have our expansile area of bone lysis, and this is basically pretty similar to geographic bone lysis. It's just that now we're getting expansion of the cortex. So you can see here, again, a relatively circular or ovoid area of lysis, but we're getting a bit of bulging of the cortex here. Okay, moving into the aggressive end of the spectrum, we have our moth-eaten lysis, and this is where we have ill-defined areas of both lysis, and depending on the type of tumor, you might also have some more radio-opaque areas as well. But basically, you're looking at patchy, relatively large areas of lysis in the bone. And it may just involve trabecular bone, but potentially can also involve the cortex as well. And then we go to our most aggressive end of the spectrum, where we have permeated lysis. And this is where we have multiple pinpoint areas of lysis that are just spreading and moving right down into the bone. Or potentially it could also be an area, pinpoint areas where we just have slightly less medullary density. And as with the moth-eaten form, it might just involve trabecular medullary bone, but potentially could also involve the cortex. Using those features, the type of periosteal reaction and also the bone lysis, the radiologist uses that information to decide whereabouts on the scale of benign to aggressive a particular lesion is. And so if we're calling something a radiographically aggressive lesion, the features that will have is this long or ill-defined zone of transition, the rapid rate of radiographic change, and this is quite important because we can use this to assist in our diagnosis, particularly if cytology or biopsies are non-diagnostic. And then a periosteal or bone lysis that's on the aggressive end of the spectrum. And you only need, one aggressive feature to call it aggressive. So whatever the most aggressive feature you can see on the radiograph, that is the one that is used to classify whether the lesion is benign or aggressive on that sliding scale. Then that lesion morphology, together with the lesion location, are used to rank your differential diagnoses. So location is quite important. So we know that osteosarcomas and a lot of our primary bone sarcomas are usually metaphyseal in location, whereas in comparison, our metastatic carcinomas, those are more commonly diaphyseal in location. And so where that lesion is going to be quite important in helping to rank, those different differential diagnoses. When you're thinking about an aggressive bone lesion, two of the most common things you might be trying to decide between are a fungal osteomyelitis or malignant neoplasia. But in general, having a sunburst or amorphous pattern of bone is usually not characteristic of an osteomyelitis. And there's other tests that we can use to assess if an animal might have a fungal osteomyelitis. So location, of course, is going to be important, and any other diagnostic tests that might be useful. So serology, antigen testing, whether the animal has some sort of tracheobronchial lymphadenopathy, that sort of stuff is going to be additional history and clinical information that's going to help you decide between a fungal osteomyelitis and a primary malignant bone tumor. This rapid rate of change is really useful in helping you reach a diagnosis because aggressive disease is going to have quite a rapid rate of change. And so, for example, your lesions of panosteitis and metaphyseal osteopathy, those lesions are usually going to regress with time, whereas with malignant neoplasia, while potentially in the early stages, you might have relatively benign radiographic changes, with time, those are going to become much more aggressive. And so by monitoring an animal over time, it may be that you can reduce the need for doing a biopsy. And, for malignant neoplasia, it may be, as minimum of 10 days after the initial radiograph, 10 days later that you might see aggressive changes on the radiograph. So it's not a huge amount of time to have to wait. So as part of deciding diagnostic challenge 1, is it reactive or neoplastic? Now we're going to sort of switch tacks from looking at the radiographic side to having a look at the microscopy. So is it reactive bone? Is it tumor bone? And by far, this is one of the most common questions that I get asked. And can be one of the more difficult decisions to make. So reactive bone, when we're talking about that, we're talking about bone that is formed by non-neoplastic osteoblasts due to any sort of insult on the bone. Anything that lifts up the periosteum, whether it's a tumor or it's inflammation, any sort of mechanical changes in circulation, any of these things can lead to the formation of reactive bone. And that's in comparison to tumor bone or tumor osteoid, where we're talking about bone that's being formed by neoplastic osteoblasts. So the real key feature of reactive bone is that you're having well-ordered maturation. And sometimes, of course, that can be difficult to appreciate in a small biopsy. When you've got the whole bone, you can quite often see that you are getting maturation of that bone, where you have initially the small spicules of woven bone, in amongst a whole lot of mesenchymal cells, but that with time they become interconnected and they organize into thicker trabeculae. Usually your reactive bone is often attached to mature lamellar bone, but again, you may not see that in your biopsy, or particularly if your biopsy isn't oriented correctly, or if, when the biopsy was collected, it just went obliquely and kind of skimmed the surface of the cortex. And so some of the other things that you might want to look at are osteocytes becoming encased at regular intervals. So it's a regular process, what's happening with your reactive bone. So osteoblasts are forming spicules of bone, and then they're quite regularly getting encased into that bone. And you don't see the same process happening with tumour bone. If you are getting osteocytes forming in tumour bone, it tends to be really haphazard, it's irregular, and it looks messy. Some of the other features that you might look for with reactive bone, you might have early on quite a lot of undifferentiated mesenchymal cells that might make you a little bit worried about them being tumour cells, but it should be a relatively loose group of cells. You shouldn't have dense streams of mesenchymal cells filling the spaces between those trabeculae of reactive bone. A little bit later on in the piece, with your reactive bone, as it becomes more mature, then you should just have a single layer of osteoblasts lining those bone trabeculae. You should not be seeing really large clusters of osteoblasts in reactive bone. The other thing is that the mesenchymal cells in those osteoblasts should be relatively bland. Shouldn't have a lot of pleomorphism, and you shouldn't really be seeing any atypical mitoses. And so these are some sort of classical examples of reactive bone. This one here actually has, this is the cortex around here. It actually has a tumour in the centre. But these are our beautiful spicules of reactive bone radiating off our cortex here. And they radiate perpendicularly to the direction of the cortex. And as they get further out into just beneath the periosteum, they become thinner. So they should be, they'll usually be thicker, closer to the cortex, and then thinner at the edge. And the thickness and the thinness of those spicules of bone are going to depend on how fast it's being formed. So if the periosteoreactive bone is being formed really, really fast, then they're going to be long and thin. If it's being formed slower, then you're going to have thicker trabeculae of periosteal bone. And then here again, we've got this beautiful web of interconnected trabeculae of woven bone, and our osteocytes here being incorporated relatively regularly through here. And you can see how up here the spicules are relatively thin, but as we get to the more mature area, that they are thickening up there. At the edge of where you're forming the reactive bone, it can be difficult to decide if it is reactive or tumour. You know, if you only had sort of this little area, then, you know, that can be a really challenging decision. And it's not always going to be possible to decide between. And quite often, it's really going to also depend on the quality of your sample. If the quality of your sample is not good, then making that distinction between tumour bone and reactive bone is going to be, you know, even harder. And, you know, we definitely shouldn't be pressured to, or feel pressured to try and make that decision one way or the other, or if you simply can't. But you can see how at the edge, even though we've got a reasonable number of osteoblasts, they're quite nice, regular looking osteoblasts. And as this becomes more mature, it's changing to being just a single layer of osteoblasts lining the surface of these trabeculae. Similarly, over here, we can see that this reactive bone is anchored to this more mature bone here, and we have these again relatively regular looking osteoblasts forming reactive bone. This is actually a liposarcoma over here, and we're getting this endosteal reactive bone formation as part of a reaction to that. Okay, so that's reactive bone. On the other side of the coin, we have tumor bone. And this is, again, it's woven bone, but it's lacking any sort of orderly maturation. So the trabeculae aren't going to interconnect in a well-structured manner. They're usually not connected to any sort of pre-existing lamellar bone. And rather than the spaces between being filled with more of a loose accumulation of mesenchymal cells, they're filled with large numbers of pleomorphic mesenchymal cells. And the type of bone that's being produced can be quite variable. And it can be anywhere from really fine ribbons or streamers to large sort of chunks of osteoid. The color can also be quite variable. So these sort of fine ribbons tend to have a real sort of glassy, pale pink color to them. Some of your larger islands may be quite basophilic, and you can have sort of quite globular to diffuse basophilia in those islands of tumor osteoid. And then your neoplastic osteoblasts are going to be highly variable with frequent or atypical mitoses. And so here's just some different examples of tumor bone. So this is our pre-existing bone trabeculae. You can see the spaces between these are filled with mesenchymal cells, and they are producing bone. And in comparison to the reactive bone that we were just looking at, you can see that the accumulation of these osteocytes into this tumor bone is much more haphazard. We're getting these weird little clusters where they're hanging out together, and they're just irregularly spread throughout that tumor bone. These ones here are more sort of little islands of tumor bone with some little areas of globular basophilia. And the basophilia is suggested to be due to an increased proteoglycan content in that immature bone. Some more examples. Here we're just getting the thinner streams just between cells where you have to have, sometimes you have to have a really good hunt for these streams. These are more of our glassy ribbons and islands of tumor osteoid. And then we've got a beautiful osteoclast just hanging out here. And then when we have a look at these cells, you can see that they're quite pleomorphic. You know, we've got some really big ones with huge nuclei here. There's a lot of nisocytosis, nisokaryosis, and atypia in these cells. Here we have quite a lot of production of osteoid. Again, these cells are being haphazardly, you know, entrapped in this tumor. We've got a mitotic figure here, which you would never see in a normal osteocyte. Here we've got some of this real basophilic osteoid, so some of this pinker material, bone osteoid, and then these more basophilic clumps as well. So there's quite a few different patterns of, you know, what that osteoid can look like. But you can see that none of it is really particularly organized and definitely not going under any sort of maturation like we'd expect with reactive bone. Even when you look at necrotic bone, sometimes, you know, you look at it and think that probably looks like tumor bone. So again, we have kind of these unorganized ribbons of osteoid interspersed between these necrotic cells. So some other things just to make our lives a little bit more difficult. We have some additional things that we need to consider. And one of those is that in osteosarcoma, we're probably going to have both tumor bone and reactive bone. And so super common, as I'm sure you're aware, to have biopsy samples where heaps of the sample is reactive bone, and then you just have that one biopsy where you can see some tumor bone. The other thing is if your osteosarcoma has breached the cortex and is sort of permeating through that periosteal bone, or you've got some endosteal reactive bone, then you might have tumor cells with tumor bone between your trabeculae of reactive bone. And so again, that's adding a sort of another level of complexity to your decision. And so having the radiographs in these cases is going to be really helpful, particularly if you have those intra or post-biopsy radiographs, so you know exactly where that needle has gone into the tumor. Okay, so I've been talking for quite a while. So now it's time to put some of this into practice. We've got a couple of little polls for you to do. Bianca, are you able to pop that up? Yes. So question is this, what type of bone are we seeing in this image? Is it reactive bone, which is A? Is it tumor bone, which is B? Is it reactive bone and tumor bone, which is C? Or are we just throwing our hands up in the air and saying, I don't know? Okay, so I mean, I'm assuming you guys can also see the poll. It is looking like most people have gone for A, which is what I would have said, that this is reactive bone. Couple of people throwing their hands up in the air, and then some people thinking about tumor bone or whether there's both. And the things that make this reactive bone for me is that we really, for the most part, have just a single layer of osteoblasts lining the surface of these bone trabeculae. And then the other thing that we can see is that these trabeculae look like they're getting thicker. So up here, they're relatively thin. This is just new bone that's being formed here. But as we move further down into the image, we can see that those trabeculae are thickening up. And then our osteocytes are being incorporated into here relatively uniformly. Okay, we'll go on to our next one. Bianca, are you able to refresh? Yep, perfect, thank you. So again, the same question, what type of bone is present in this image? So we've got reactive bone, tumor bone, reactive and tumor bone, or there's always the throw your hands up in the air option. Okay, yeah, this one is clearly too easy for you guys. And so, yep, 96 or so % of you have gone with tumor bone. And yeah, we just have, well, one, we have these really pleomorphic mesenchymal cells here, and then just fine little ribbons or streamers of osteoid between these cells. There's no indication that this bone is undergoing any sort of maturation. We're not getting any osteocytes being incorporated into it. And so, yeah, this is really beautiful tumor bone. Okay, next one, leveling up a little bit now. So what type of bone have we got here? Is it reactive bone? Is it tumor bone? Is it reactive and tumor bone? Or I don't know. Yeah, so this one's quite a bit tougher because most of this sample is necrotic. But regardless, I think that we can see that most of this, as most people have said, we've probably got some reactive and tumor bone in here. But the vast majority of this here is probably all going to be tumor bone. It looks, when you look at it, it just looks messy. If this was going to be reactive bone, then between here and here, we should be seeing some maturation in that bone. So we should be starting out with the thin area, thinner trabeculae, and they should be becoming thicker with time. Whereas here, we've just got these random, quite messy looking spicules of bone. Possibly right down here at the bottom, I think it's hard to know for sure. We might have a little bit of reactive bone, but the vast majority of this is necrotic tumor bone. Okay, last one. This one, what type of bone is present? Reactive bone, tumor bone, reactive and tumor bone, or there's always the throw your hands up in the air option. Yeah, so I mean, as the last one, this is clearly the hardest of the four. And actually what's super helpful in this decision is actually seeing the whole of the picture, because most of this bone here is endosteal reactive bone, but we have these mesenchymal tumor cells invading between and around that reactive bone. So the things that make this reactive bone over tumor bone are, again, our osteocytes are being relatively regularly encased in the osteoid. When we look down here, you can see we've only got a single layer of osteoblasts that are forming this bone, but clearly we also have these mesenchymal cells invading around here with mitoses, which clearly look pleomorphic and malignant. We'd probably have quite a big question mark over this bit of bone here as to whether I would probably lean to that being some tumor bone that's being formed by these neoplastic cells. So if you went for tumor bone and reactive bone, then I think that would probably be the right answer with that one. Okay, so that's the last of our polls for a little bit. We might get to some others. So I guess the question is, if we're struggling with deciding between reactive and tumor bone, are our radiographs going to help? And the answer to that is maybe. So if we had radiographic changes consistent with aggressive bone disease, combined with our metaphyseal location, if appropriate, and the signalment, if you had all of those things, then that's going to be pretty suggestive of malignant neoplasia. Where you're going to have problems is where you might have early aggressive lesions, and things are much harder also in the axial skeleton. And so in the axial skeleton, you have issues with overlying tissues. Also, the reported characteristics of bone tumours in the axial skeleton are a lot more variable than they are in the appendicular skeleton. And so that makes things a little bit more difficult as well. So your options are, even if you've got your radiographs and you've got your biopsy and you're still not sure, is to consider resampling or doing some radiographic surveillance and coming back in sort of 10 days to 2 weeks, taking another radiograph and seeing if you've got any sort of progression of that lesion. And so this is kind of a nice example of that process. So this is Jana, who is a 5-year-old German Shepherd. She has a lesion in the distal femur, and on July 30th, which was when the first radiograph was taken, you can see that this isn't looking too bad. We've just got this smooth periosteal reaction along here. And the biopsy, you can see, is just reactive bone. So we have our periosteum, it looks like, along here, and we've got our new spicules of woven bone that are steadily becoming thinner and more mature. On August the 27th, she had another biopsy, so we're now talking a month later. And here, I mean, yeah, this isn't too flash. We're looking at some trabecular bone fragments and then other material in between these, which, when we have a closer look, you know, we really could be wondering whether this is necrotic tumor bone. We've got our nice, more mature trabeculae here, and we know that because we can see this is lamellar bone, where we have our parallel lines of lamellae. But then we just have this amorphous sort of pink material in between, which we would have, yeah, we really would wonder if this was necrotic tumor bone. And that's where having a look at the radiographs that were taken at that time point is pretty helpful, because now that you can see that we've had quite a lot of progression of our lesion. Now we have this sort of irregular to columnar periosteal reaction, and it's becoming lytic in the middle here with relatively ill-defined margins. So if we were going to put those two things together, then we could have a reasonable index of suspicion that this animal has an osteosarcoma. And then we come back 10 days later, and clearly this is now post-mortem. Or actually, no, sorry, it's amputation. And you can see the periosteal reaction is even more pronounced, and that we have this tumor that is permeating through our medullary cavity here. And in the space of, 13 days, our periosteal reaction has really expanded. We're now getting this moth-eaten lysis in here, and lysis out here as well. So we're definitely now at this sort of aggressive end of the spectrum. And this is where that zoomed in reactive bone was taken from. But you can see that clearly we have these mesenchymal cells that are permeating through that medullary cavity and around these areas of endosteal reactive bone. And when we look at different areas of the tumour, we can see that these cells are producing tumour osteoid, and so we can feel quite comfortable with calling it an osteosarcoma. But definitely, I think, you know, if you only had that biopsy without the radiographs, I mean, definitely you'd be wondering about tumor osteoid, but I don't know how comfortable you would feel about really putting things on the line. But seeing the progression of the radiographs from July to August, you know, I feel like you can feel a little bit more comfortable about saying that, you know, you think this could be an osteosarcoma. Okay, moving on to our diagnostic challenge number 2, and that is trying to decide between a fracture callus and a tumour. And so this is when you have the biopsy that is containing mesenchymal cells producing different types of matrix. And so depending on the stage of fracture healing that you might be at, you can have you might have osteoid in there, you might have cartilage in there, you might have more fibrous tissue in there. And so you can be looking at anything from an osteosarcoma to a chondrosarcoma to a fibrosarcoma or a fracture. And then an additional complication that we have is that our bone tumours are commonly destroying normal bone structure. And so it's common to also have pathological fracture when we have bone tumours. So like we have with reactive bone, the key feature that we have with a fracture callus is, again, that organised maturation. And so with reactive bone and fracture callus, we're thinking about things being organised and mature, whereas with tumours, we're thinking about things being disorganised. And so with our fracture callus, orientation of your biopsy is going to be quite important because we have maturation occurring from the outside of the bone inwards to the bone. So that might be quite useful if your biopsy, I guess, is oriented appropriately. You might also, depending on the stage at which you have the fracture, you might have some hemorrhage, some necrosis and inflammation, and you're usually going to see that you know, in the first week or so after fracture, or I guess if the fracture is longer standing but is moving. With a little bit more time, you start to get the production of cartilaginous matrix with some intramembranous bone ossification occurring along the periosteum. And in animal models, so we're talking rabbits and rats, that process can be seen as early as a week after fracture. There's not a lot of literature on what the timing of that would be in the animal species that we deal with, but you know, ours really aren't under those well-controlled experimental conditions. But certainly by sort of 10 days to 2 weeks after the fracture, you can be expecting to see that sort of cartilaginous matrix being produced. And then that cartilaginous matrix undergoes endochondral ossification to form bone, and you also have more intramembranous bone formation happening. And so that's becoming more prominent in your sort of 2 to 4 weeks after the fracture. But I guess the problem we have is that we may not necessarily be able to appreciate this maturation in our biopsy. And so some of the things that you might look for to indicate that it is a fracture callus over a tumour is that you have those nice plump, round reactive osteoblasts. They have that abundant cytoplasm, they have that pale Golgi area next to the nucleus, and you just have some mild anisokaryosis. You don't have the marked pleomorphism that you'll see in an osteosarcoma, and you don't have the atypical mitoses that you're going to have in osteosarcoma. Your trabeculae of woven bone, as with reactive bone, should be lined by just a single layer of osteoblasts. And while the space between your trabeculae may be filled with mesenchymal cells, it's usually a mix of vascular tissue and fibroblastic cells. And so what you might see with granulation tissue is not as highly cellular as you might see with a sarcoma. The other thing that you see, you may see also, is remodeling of your necrotic bone. And while you do get necrotic bone in osteosarcomas, you don't usually get the remodeling happening. This is an example or a case study of some of this decision making. So this was a 6-year-old greyhound with a fractured humerus, and this is the fracture area. So you can see we've got some fibrin down here, we've got some cells in here, and these are our normal trabeculae of bone here. And so looking in a little bit closer, we've got these trabeculae of bones. Have a close look at these because you're going to be making some decisions on this in a second. Again, trabeculae of bone, and then this is the tissue that we have in between these trabeculae. So, Bianca, if we could have the poll up again, that would be awesome, please. Your question is, what is your diagnosis based on these images? Are we looking at something non-diagnostic? Is it an osteosarcoma? Is it we can't make a decision on what sort of tumor is sarcoma, or is it fracture associated? Bianca, do you know whether is the poll up? I can't see it on my screen. I'm not sure. Oh, there it is. Okay. Thanks, Bianca. Okay, yeah, so we've got a clear favourite answer there, and that's D, fracture associated, which I agree with as well. The reasons that we're thinking fracture associated with this one are that our trabeculae here are only lined by a single layer of cells. So these look like reactive bone trabeculae. And the tissue between here, yes, they're mesenchymal cells, but they're not closely packed together. We've got a lot of blood in here as well. And so this is a lot of the healing tissue, probably some granulation tissue in the more mature areas that is part of the fracture healing. The other thing we can see down here is, well, this bone isn't necrotic. We have got some osteoclasts that have come in to remodel this tissue as well. But that is not all that we have in this slide. So this picture that you probably recognize from before when you had to decide if that was reactive or tumor bone, this is another area of the slide. And then another area here. So in these areas, we move more to deciding that we think it's an osteosarcoma. And that is because we've got far greater cellularity between these trabeculae in comparison to those pictures we were looking at before. And when we look at this bone here, we can see it's the thickness of it is actually pretty similar to the thickness of the trabeculae that we were looking at before, but we don't have any osteocytes incorporated into this. It's quite irregular looking. We've got little circular clumps, and then we've got other bigger clumps, some with a reasonable amount of basophilia. And then we've got some pleomorphism of our cells in between here. And when you look around, a relatively high mitotic rate. And so this dog had a pathological fracture secondary to its osteosarcoma. So, of course, you may have the two processes that are happening in the same slide. And so for sure, having the radiographs in these cases is going to be massively helpful. Knowing that you've got a fracture there is really going to assist in your interpretation of your samples. If you don't know you have a fracture, that's going to be quite a bit harder for you to be making those decisions. So knowing that you might have two processes, as you can quite clearly see in this radiograph, we've got fractures, but also we have this permeative lysis through the diaphysis here. And so we've clearly got a tumour that has led to this pathological fracture. Okay, our final diagnostic challenge is when we have matrix on a bone biopsy, but we don't have any osteoid. And so determining between an osteosarcoma and our other tumour types is quite important prognostically because our osteosarcomas do have some of the worst prognosis. And so we do, if we can, want to try and decide between whether we have an osteosarcoma or some other type of bone sarcoma. The problem we have is that in an osteosarcoma, it can be highly variable in different areas. And so you may have areas where you only have collagenous matrix, but in another area is where you have your osteoid production. And so in a small biopsy, trying to decide between your osteosarcoma and your other types of sarcoma can be quite challenging and if not impossible. And so if we have a lot of cartilaginous matrix, you know, we might be considering, have we got a chondroblastic osteosarcoma or a chondrosarcoma? If we have a lot of giant cells, we might be thinking, is it a giant cell rich osteosarcoma or a giant cell tumor of bone, etc. And so we shouldn't be trying to subtype things on biopsies because of the variation in osteosarcomas in different areas. What I'm trying to get to in this section is trying to differentiate between whether it's a type of osteosarcoma or another type of sarcoma. So when we're thinking about a chondroblastic osteosarcoma versus a chondrosarcoma, we're thinking about biopsies where we might only have cartilaginous matrix present. Sometimes in chondrosarcomas, also sometimes see it in osteosarcomas, chondroblastic osteosarcomas, we do have some endochondral ossification happening. And so we do need to distinguish between what is normal endochondral ossification and what is tumour bone. And so tumour bone is bone that's going to be produced directly from our neoplastic osteoblasts, and there's no intermediary cartilage middle step. Endochondral bone ossification, or bone that's formed through that process, happens when you have this sudden transition between the cartilage and the bone that's being formed. And you can see this quite nicely in this example, which I attended the Western Conference a few weeks ago, and this was a chondrosarcoma case that was presented, and I thought it was a really beautiful example of endochondral ossification in a chondrosarcoma. And so you can see we have our cartilaginous matrix here with our chondrocytes, and then this abrupt transition between our cartilaginous matrix and our bone. And so this is bone that is being formed directly from the cartilage in endochondral ossification. It's not being formed directly by tumour cells. On imaging, differentiating between your osteosarcoma and your chondrosarcoma primarily involves the location of the lesion. And so chondrosarcomas are considered to be more common in our flat bones, so our ribs, a skull, pelvis, that sort of location, whereas osteosarcomas are more common in our long bones. course, this is not infallible. You will have osteosarcomas forming in those flat bones, and conversely, chondrosarcomas in the long bones. But on the law of averages, these are the locations in which they're more common. Unfortunately, our ALP staining may or may not be helpful. So in one of the papers that has reported on ALP staining, I think it was 1 out of 4 of the chondrosarcomas was positive on the ALP stain. In my experience, I haven't had any chondrosarcomas that were positive on ALP, but that could easily be because I haven't looked at the cytology of enough. Are there any specific IHC markers? And the answer to that would be probably no again. Osteocalcin, which is considered to be an osteoblast marker. In one study that looked at the IHC of osteocalcin in chondrosarcomas, all of them were positive for osteocalcin. And the reliability of that also apparently depends on the clone of the osteocalcin that you're using. And so, in fact, it may, on a small biopsy, be impossible to tell between a chondroblastic osteosarcoma and a chondrosarcoma. You might suggest one more over the other based on the location, but that's not going to be definitive. So here is a case example from a 7-year-old domestic short hair. It has a firm mass protruding from the proximal tumor, proximal femur, which you can see coming out here. It's quite a large mass. It's periosteal, so it's coming off the edge of the cortex here. While there is some scalloping, a little bit of this cortex on CT, you can see that actually mostly the cortex is intact. So it is coming off the edge there. This is the cytology of that mass. And so you can see that the color of this matrix is the type of color that we often associate with cartilage matrix. So this is Diff-Quick stain, and it's kind of this intense magenta-y sort of color. And we can see our cells here sitting almost, can kind of imagine them and their little lacunae in the matrix. But on ALP stain, these cells are ALP positive and quite nicely positive. So you can see the cell here, he's filled with these brown-black staining, but we still have, I guess, the purple matrix in the background. But yeah, these guys are pretty nicely positive. So in this case, we'd actually think, well, we have all of this cartilaginous matrix on our cytology, but these guys are ALP positive. So do we actually have an osteosarcoma? Yes, bearing in mind that the occasional chondrosarcoma can be ALP positive, this would be pretty suggestive of this being an osteosarcoma. On the histology, you can see why we've gotten that color matrix out on the cytology, because the vast majority of this tumor is actually made up of cartilage. We can see that it's quite nicely periosteal. Here's the cortex here, and then it is just coming off that layer of the cortex. But we do have some areas in this tumor where we have tumor cells directly producing osteoid, which does make this a chondroblastic osteosarcoma rather than being a chondrosarcoma. So here it's quite a bit more of a cellular area. We've got some mitoses, and it's producing this pink, sort of quite glassy, and also up here and over here, matrix that would be consistent with osteoid. And so this is actually a feature of periosteal osteosarcomas, in that they do tend to have quite a large cartilaginous component, and you have to hunt around for those islands of osteoid. Okay, one of our other decisions is deciding between a telangiectatic osteosarcoma or hemangiosarcoma, and differentiating between these is going to rely on you identifying either the presence or absence of tumour bone. And as with all of these things, this may simply not be possible in a small biopsy. Imaging of the bone isn't necessarily going to be helpful in helping us make this distinction. So a study of 70 dogs found that there were no differences in the radiographic findings between a telangiectatic osteosarcoma and a hemangiosarcoma. But there is some other important additional information to consider. So with our appendicular hemangiosarcomas, the majority of them are reported in the hind limbs, 78% compared to 31% for telangiectatic osteosarcomas, and 50% of those are in the tibia. So the tibia, proximal tibia, seems to be quite a common location for our hemangiosarcomas. We may also see some differences between our hemangiosarcoma and our telangiectatic osteosarcoma based on our disease staging. So with our hemangiosarcoma, we might also have other metastatic or primary tumours. So we might have some pleural or pericardial effusion, we might have an enlarged spleen, and all of those things would be uncommon in an osteosarcoma. Similarly, the metastases that you see with a hemangiosarcoma, rather than being miliary, and they're not as well defined or nodular as we might see with an osteosarcoma. And we might also see larger areas of soft tissue opacity because we might also have some hemorrhage in there as well. But immunohistochemistry is really going to be your guy for helping with this one. So doing your factor VIII related antigen or CD31 to identify those endothelial cells. And so in one study that used this immunohistochemistry, after they did it, 6 out of 43 of the tumours that had previously been diagnosed as a telangiectatic osteosarcoma were reclassified as a hemangiosarcoma. On the other side of the coin, one hemangiosarcoma was reclassified as a telangiectatic osteosarcoma. But one of the nice things about this study is that when there was obvious tumour bone present, then that did allow definitive diagnosis of your telangiectatic osteosarcoma. Where your difficulty comes is when you don't have that tumour bone. Potentially, you could also look at using osteocalcin, but it's not as widely available or as easily used as your factor VIII related antigen. But in one study that looked at it, none of the hemangiosarcomas were positive for that. And of course, by far the easiest thing to do is to do ALP staining of your cytology smears. So in this case study that we have here, this was a 12-year-old German shepherd, and it had a lytic lesion in the proximal tibia, which you can see here, where we have this sort of patchy moth-eaten lysis. We have, and probably we're looking at maybe some amorphous type periosteal reaction. This is cytology of this lesion, and so we've gotten out mesenchymal cells. They've got these nice spindle shape to them. They have a lot of anisocytosis, anisokaryosis, mitotic figures around. So this is looking like a bad tumour, and I think we could confidently say would be consistent with a sarcoma. And then this is the histology of this. And so we've got tumour cells forming or lining blood-filled channels and looking, quite nicely like a hemangiosarcoma. One of the things that can be a little bit difficult, I find with some hemangiosarcomas, is where you get areas of collagen production, because sometimes you spend some time looking down there going, is this collagen? Is this osteoid? And I think when we look at this image in particular, we can see that rather than this having the sort of glassy, homogeneous eosinophilic appearance to it, like we'd expect with tumor osteoid, it looks quite fibrillar. And so we could feel relatively comfortable with calling this collagen rather than tumor osteoid. But if we weren't sure, then really doing ALP stain on these guys is going to be super helpful, or doing immunohistochemistry. Okay, our next one, or decision, giant cell osteosarcoma versus giant cell tumor of bone. The challenge for this is when we have a biopsy with large numbers of giant cells and not much osteoid. So giant cell tumor of bone is rare, and a lot of the information that we know about it, we have extrapolated from human medicine. There's not all that many cases of giant cell tumor of bone in the literature for animals. In humans, it's considered to have 3 cell types. So a fibroblastic spindle-shaped cell, which is considered to be the neoplastic cell and has osteoblastic lineage. But often the majority of the cells are mononuclear cells, which have monocyte macrophage cells, and then the multinucleated giant cells. And these guys are recruited to the tumor. So the key features of a giant cell tumor of bone is that there should be no to minimal tumor bone. If you have a reasonable amount of tumor bone there, then it's going to be a giant cell osteosarcoma. Bearing in mind that at the edge of a giant cell tumor of bone, you can have some reactive bone, and you don't want to be misinterpreting that as tumor bone. One of the other features of giant cell tumor of bone is it can have a really high mitotic rate, but you shouldn't be seeing a lot of atypical mitoses. And then your fibroblastic and mononuclear cells don't have a lot of evidence of pleomorphism, and that's in comparison to your giant cell osteosarcoma, where you do have marked pleomorphism and you have your atypical mitoses. On imaging, they do also look quite different. So your giant cell tumor of bone is more of a benign looking lesion, so it's predominantly lytic. You don't have a lot of periosteal reaction, and you have quite a short zone of transition. If you're seeing tumor bone on your radiograph, again, that's going to be a giant cell osteosarcoma and not a giant cell tumor of bone. In humans, giant cell tumors of bone are usually epiphyseal in location, and they can erode the cartilage and spread into the joint, in comparison to our osteosarcoma, which are usually metaphyseal in location, but they don't often cross the joint. I suspect that the ALP stain is probably not going to be of assistance here. I'm not aware of anyone that's done a study looking at it, but given that the tumor cells are an osteoblastic cell line, I would suspect that they are going to be ALP positive. This case study here is a 6-year-old Rottweiler. It has a lytic lesion in the distal ulna, and you can see some pretty impressive lysis. We've got a lot of expansion of our bone here, a lot of periosteal reaction, and almost, we'd say, permeative lysis up through here. So already we'd be pretty suspicious about this being an aggressive bone lesion. And then this is the subgross from this. This is our cortex around here with our periosteal reaction. And this entire medullary cavity is just permeated through with tumor cells. It's broken through and is heading out into the soft tissue as well. When we look a little bit closer, we can see we've got quite a lot of giant cells. It was a real feature of this tumour. And it was sent to me because, you know, the pathologist was trying to decide, is this a giant cell tumour of bone, or is this a giant cell rich osteosarcoma? But the things that make me think this is a giant cell rich osteosarcoma is just the sheer amount of osteoid production. While we can get very small amounts of osteoid production in a giant cell tumour of bone, it shouldn't be this amount of osteoid production. So if we're getting a decent amount there, then that would be more consistent with a giant cell osteosarcoma. And to give you a comparison, this is a giant cell tumour of bone. And you can see that we've got heaps of giant cells here. They can have a huge number of nuclei in their cytoplasm, but the nuclei are all kind of similar to a lot of the nuclei round about them in the mononuclear cells, which is another feature of giant cell tumours of bone. And they can have that really high mitotic rate, which you can see in this image here, but no osteoid production. Okay, our final one to decide between is fibroblastic osteosarcoma or fibrosarcoma. And this is when you might have the biopsy where you have a large amount of collagenous matrix, a lot of spindle-shaped mesenchymal cells, but you don't have any osteoid. So on imaging, your fibrosarcoma is usually primarily lytic with not a lot of periosteal reaction. In comparison to your fibroblastic osteosarcoma, which tends to have more periosteal reaction. But by no means is that a slam dunk. You will get, you know, tumours that are going to break the rules, but these are, I guess, general features. But the real kicker and the easiest thing to do in these cases is to have cytology and to do your ALP staining. So this is a case study from an 8-year-old Labrador that had a mass in the distal humerus. And this is some of the histology that we have here. So we've got sort of streams and bundles of spindle-shaped cells, mesenchymal cells. We've got some mitoses through here. We're not seeing any osteoid. And then this is the cytology of this lesion as well. So again, we've got spindle-shaped mesenchymal cells. We've got a lot, some anisocytosis, anisokaryosis, some multiple nuclei, some regionally large nucleoli, small amounts of matrix production, more in this one. So again, on cytology, a lot of evidence to suggest this is a sarcoma. I guess the question we have is this a fibrosarcoma, or are we looking at a fibroblastic osteosarcoma? And so this is our last poll, last decision that you need to make. So what is your diagnosis? Is this non-diagnostic? Is it a sarcoma, fibrosarcoma, or a fibroblastic osteosarcoma? I should say also, sorry, here are the radiographs from this lesion as well. Okay, we're having a few less people committing to this one. Other than that, you've all gone to sleep already. Okay, so we've got a fair spread of answers here. So sarcoma, fibrosarcoma, fibroblastic osteosarcoma. And to be honest, based on everything that I've seen, I would probably, if that was a biopsy, be suggesting a sarcoma. Radiographically, we have got a little bit of amorphous periosteal reaction and maybe a little bit of moth-eaten lysis. So we're definitely looking at an aggressive bone lesion, which might make me think a little bit more about a fibroblastic osteosarcoma. But yeah, in no way at this point do I think that I could be definitive. But this is the ALP stain of that cytology. And we've got some beautiful brown-black staining of these mesenchymal cells. So that would be pretty good for telling us that these are osteoblasts and not fibroblasts, and that we are actually looking at a osteosarcoma. And then I didn't show you these areas, but in other areas of the tumor, we can see that we do have spicules and streamers, ribbons of osteoid between our mesenchymal cells, which again is going to be consistent with a fibroblastic osteosarcoma. And so I guess, you know, what all of that is showing us is we're really needing all of the information to help us come up with a diagnosis, and particularly on small biopsies, making a definitive diagnosis may not be possible. And I think it's just worth reiterating that, you know, we shouldn't feel pressured to make a diagnosis when we can't. The other thing is that I don't think we should be trying to attempt to subtype osteosarcomas on a biopsy because they are so variable in different parts of the tumour. But really, one of the #1 things that you can do for helping you decide on osteosarcomas is doing an ALP staining. It's really cheap, it's really easy to do, and it's super helpful in identifying osteoblasts. And so veterinarians, when they're taking biopsies, really should be collecting cytology samples at the same time as they are doing that. And then if we have all of the information, I realize we don't always get all of the information, but if we have that location, those radiographs, and that histology, you know, we may be able to come up with our most likely diagnosis. And so when people are sending me second opinions, I'm always asking them for the radiographs because I find I'm much more likely to commit to a diagnosis if I have the radiographs with those. And so, you know, we need to start, I guess, this from the beginning and training our clients, and certainly those of us in vet schools training our vet students as well to send in their radiographs when they are sending in bone biopsies. So yeah, finally, thank you guys for coming out on a Saturday, coming out or sitting in the comfort of your own home on a Saturday or a Friday night to come along to this talk. Again, I'd like to thank Sarah and Devon for all of their diagnostic imaging assistance. And certainly I wouldn't be here today without Keith Thompson, who's been an amazing mentor in my life and is also responsible for a couple of the bone cases I presented today. And then if you wanted to read more about everything that is in this talk, then this article in the recent Vet Path has a lot more detail and also information about using radiographs with your histology. And then finally, just a plug for this book, which will be out very soon. It's at the printer, possibly even, I think it's on sale even, which is the latest fascicle. This one's on tumours of bone and cartilage, and also dental and tooth tumours as well. So if I do say so myself, it's an excellent book. Cool. Well, that is all I have. So I can probably look at answering some questions. First question, what is the source for the ALP stain for the cyto? I get it from a company called Australian Bioscience. So if you're in Australia, it's probably going to be quite easy for you to get it. When I order it, I normally order a whole heap of bottles because the price of shipping is more than the cost of the stain. But yeah, if you're in Australia, that would be quite easy for you. In other countries, I don't know where you would get it from. I'm sure any of your local diagnostic companies could help you out with that. Is it necessary to apply the ALP stain on formalin fixed tissue? The problem with formalin fixation is it often inactivates the ALP, and so it's not always great. So there are a few papers that I think have looked at ALP staining in osteosarcomas from a prognostic point of view, but they haven't looked at whether other tumours also stain with the ALP, or so immunopositive for ALP. And so, yeah, we don't really have that in our armory at the moment. So this is really just for cytology. With progressive bone lesions, you mentioned 10 days for radiographic changes. Would progressive histological changes be evident in the same time period or earlier? Not entirely sure what we're meaning here, but like in the initial stages, of course, you're still going to have the tumor there, but I guess 10 days later, that tumor is going to be bigger, and so you're probably going to find it a bit easier to get out on your biopsy. And so again, yep, potentially if you re-radiograph in 10 days time and you re-biopsy, that's probably not a silly idea. Hopefully that answers your question, Rick. Shannon, sorry, does the matrix vary in appearance in osteosarcoma versus chondrosarcoma versus fibrosarcoma? The osteosarcoma, you can have a whole different types of matrix. So you might have collagenous matrix, you might have cartilage matrix, but what you need for the diagnosis is tumor bone. So if you have tumor bone in there, tumor osteoid, it's an osteosarcoma, regardless of all the other types of matrix that it's producing. We use those other types of matrix to subtype it into the different types of osteosarcoma. For it to be a chondrosarcoma, you have to have cartilaginous matrix. You might have endochondral ossification and have some bone, but you shouldn't have tumor bone. For a fibrosarcoma, you don't have tumor bone, you don't have cartilage matrix, you just have collagenous matrix. So hopefully that answers your question, Shannon. Anonymous, I don't recall if it was mentioned, but what reagent do you prefer to decal? Beautiful photos, thank you. So usually I use a HCl based product. If I really want something to look pretty, I use EDTA. But yeah, usually I just use an HCl based product, but I keep a close eye, I guess, on the decal. Very informative, thank you. Thank you, Shahaza. Alison, are there any studies showing a significant increased risk of metastases while waiting to re-radiograph? Yeah, that's a good question, and I don't know the answer to that. You kind of hope that 10 days wouldn't make as much of a difference, but definitely that's going to be a risk. So you're going to have to weigh up the weight of 10 days versus, you know, the extra cost and invasiveness of having to do more biopsies. Kia ora, great talk, thank you. For commercial labs, we often use rapid decal. I always felt it wasn't possible to then use IHC. Yeah, so your HCl decal solutions are definitely going to affect your IHC. So in the study that we did with the osteocalcin, we still got osteocalcin staining with the HCl based solutions, but it wasn't as nice or as pretty as what we got with the EDTA solution. And then the formic acid was sort of in between there. But we did still get staining with the osteocalcin. And I believe from the hemangiosarcoma paper, those were also similarly decaled, and they still got the factor 8 staining. But, you know, it's going to depend on how, you know, harsh a process that's been. It's definitely going to impact your IHC. So I guess, yeah, if it's positive, I suppose you're quite happy. Yeah, I guess you're going to need to know. You could probably tell also, look, based on looking at your biopsy, you know, does it look really trashed by the HCl, or is actually looking quite nice, and therefore maybe your IHC is going to work a little bit better. But yeah, no, you're right. Definitely the IHC, the decal is going to impact that. So yes, we can use it with acid solutions. It's just not always going to be as good. Julie, do you place any significance on osteoid enveloping individual cells? One of my colleagues says this supports a diagnosis of osteosarcoma. Not entirely sure. So when you have reactive bone, you have osteoid enveloping cells. So I'm not entirely sure whether there's some other level to that. What I would say is if the incorporation is irregular and haphazard, then I would definitely be thinking malignant osteoid. If it's regular, then depending on what other things are happening, I'd be more likely to think reactive. Madeline, histiocytic sarcomas can produce lytic bone, often in both sides of the joint. Any other ideas for differentiating from other bone tumours? So yes, so obviously, again, having tumour bone is going to be key here, but also you have some excellent IHC markers for histiocytic sarcomas as well. Because it's on both sides of the joint, that's actually ruling out things, or making far less likely your osteosarcomas and your tumours like that. I guess you'd be thinking along the lines too of synovial myxoma, myxosarcoma, which looks quite different, or your soft tissue type sarcomas, which again look different. Yeah, there's going to come down to, I guess, what the cells themselves look like. And as I say, your IHC for histiocytic sarcomas is also really great. Is it possible to use 18 gauge needles to obtain cytology samples from bone? Yes, it is. So the literature suggests that 21 to 22 gauge needles are most commonly what is used. But I have heard of a lot of people having success with bigger size needles as well. Okay, are there any other final questions? Speak now or type now, forever hold your peace.